Okay, so I'm here with Dr. Robert Reiner, and he's the Executive Director of Behavioral Associates in New York City. So we're going to talk a bit about some of the work that he's doing in New York City with biofeedback and also with virtual reality and so on. Um, you have been doing a lot of work with people who have anxiety problems and phobias and so on. And virtual reality has come to be like the gold standard in dealing with problems like this. But it seems like in mental health, there's not a lot of people that are using it. Why do you think that is?
Well, the expense, first of all, it requires additional training and a pretty substantial investment, which has actually been reduced dramatically because of YouTube.
Wow.
Initially virtual reality, the huge expense is something called the tracker. The
Uh-huh.
tracker sits on top of. Well, I can show it to you. Hold on a second. Can you see this right here?
Yes.
Okay. This is uh, basically a head-mounted
Pull it
display,
back a little bit.
Sony headset.
Yeah, good, great.
Okay, so it's a 3D glasses basically made by Sony,
Uh-huh.
and they're. Let me see if I can show you the image comes up right here. So the patient puts these on,
Uh-huh.
and this is the important piece right here. I'm going to pull it off to show you. This device right here is a tracker.
Uh-huh.
It's think of a wireless mouse in reverse. That's what a tracker does. So when you turn your head in virtual reality, the world turns with you.
Oh, okay.
The screen is redrawing itself. I think it's like 30 times a second.
Wow.
So it requires an intensive amount of programming. Hold on a second. Which is what made the protocol so expensive. If you wanted to buy a fear of flying program, it was about $15,000.
Wow. And that's for the program.
Yeah, that's for the complete headset. It's for the hardware and the software.
Okay.
But $15,000, especially back in 1999, when this stuff first became available, is a lot of money for most psychologists.
Sure.
Unfortunately, a lot of psychologists don't think like business people,
That's right.
and in a way, that has really been useful to me because it's less competition. There are very few people doing this in New York, and I think in general, people have shied away from it for a variety of reasons, which I'll
Uh-huh.
get into. But it works. It
Now,
works
now
amazing.
with the
Yeah.
you mentioned like the fear of flying hardware and software being around 15,000. Now, what if, let's say, you wanted to work with other types of phobias? Would you need to just get additional software or?
Yeah, well, the 15,000 really was what the the company that I was doing business with called Virtually Better.
Uh-huh.
They're out of Atlanta, and they pretty much are. That's the only game in town, and at least as far as I know in the United States, virtual reality.
Mm-hmm.
It's not a real big market.
Right.
Um,
Yeah.
there's been a buzz lately because of the Oculus whole thing,
Mm.
but still, for the most part, it's a pretty slow market. Yeah, I interrupted you. What were you going to say,
No,
Harry?
I was saying that in terms of virtual reality and usage of it, I'm familiar with the work, some of the work that you're doing, and really the only other work that I can think of that I personally was somewhat familiar with was related to the military.
Yes, a lot of work with PTSD,
Hmm.
and also following 9/11.
Right.
There were a lot of people that were traumatized by what they experienced, and virtual reality was really the gold standard, as you said before. And from a therapist point of view, I can't tell you how gratifying it is when somebody can come in and who's never flown or who maybe had a major panic attack on a plane and won't get back on a plane, or may not even be allowed on a plane. Um, I'll tell you that story in a second. But and you can pretty much tell them when they're going to fly after you collected baseline data.
Wow.
Mean length of treatment is 12 to 16 weeks, and the success rate's over 90%
Wow.
if somebody complies with the treatment protocol. And what we found when we first started doing it, we were getting success of about 60% just with virtual reality alone. 60% is still respectable. I mean, that's what the drug companies brag about with the SSRIs. But when we added a specific type of biofeedback, which was heart rate variability or respiratory sinus arrhythmia, our success rate jumped to 92%.
Wow, that's kind of leads to the next thing I wanted to ask you about. So we were talking about the virtual reality, and not too many people using that. But then I also know that, of course, you use biofeedback. You mentioned heart rate variability, but I know you do other forms of biofeedback as well, which we'll talk about later.
It's true.
But so you have biofeedback, and you have some mental health professionals that are using biofeedback, but and they may be using biofeedback with anxiety problems and with phobia problems, but
Yeah.
not combining them with combining the biofeedback with virtual reality, and you're really, I would say, a pioneer in that area in combining them. And what can you say about, how you came to decide to use them together, and how that works?
Okay, that's a good question. I'm glad you asked. I remember as a grad student studying Volpe's techniques, systematic desensitization, and saying to myself, it's theoretically, it seems to make sense. The counter conditioning procedure. And Volpe's procedure was basically having patients imagine a fearful or phobic stimulus, like being in a plane. And his instructions were to describe it to the patient, bring them through it almost the way a hypnotherapist would do it. And the patient would be taught deep muscle relaxation and then be brought through imagery techniques, Volpe's desensitization procedures. The idea was to set up what's called a counter conditioning procedure, because he believed that most patients, when they visualized being on a plane, if that's what they were afraid of, or public speaking, imagining you in front of an audience, people get extremely anxious.
Right.
He wanted to break that up and substitute, through counter conditioning, a deeply relaxing response through the deep muscle relaxation training. And I said to myself, here I was 26 years old, but you know what? I remember shaking my head thinking, it sounded great, but I couldn't ask someone to do it with a straight face, because in my limited knowledge of what I knew about human nature, there's no way anybody was going to generate meaningful imagery of something they spend their whole life avoiding.
Right.
They weren't going to do it. And I don't even think I can ask people. And the whole idea of a SUD scale, where that stood for subjective units of discomfort, you're expecting the patient to label their anxiety on a 1 to 5 point scale, with 5 being I'm jumping out of my skin and 1 being I'm on a beach in the Caribbean. And they were supposed to rate it. And once again, from all the experience I've had with biofeedback, it's clear to me that there's a huge gap between what patients, when they think they're getting anxious, and when they're really getting anxious. Anyone who's ever done GSR or temperature training biofeedback knows that.
Right.
So subjective response didn't appear to have a whole lot of validity or any kind of meaningfulness to me in that procedure. And I remember thinking, this was 1978 when I first learned this stuff, that if something like virtual reality ever became available, it would change our profession. Because I thought that Wolpe's theory made a lot of sense.
Right.
But there was no technology available. And sure enough, 20 years later, I'm watching CNN and I see that Pentium computers had finally become powerful enough to drive the program.
And now they're so slow.
And yeah, but I immediately got online, and there wasn't internet then.
Right.
And there was a conference 2 weeks later in New Orleans, and I flew down there and met the players of the game and got really involved. And I invested in that system. We already had biofeedback equipment.
Mm-hmm.
We used thought technology stuff
Mm-hmm.
for general biofeedback. We were not doing much EEG training at the time.
Mm-hmm.
And I had this suspicion that when we figured out what type of biofeedback we would use, it wouldn't be EEG, mainly because you've already got a headset on people, and that would compromise the EEG signal,
Sure.
having a head-mounted display. So we were going to look for something else. My first thoughts were GSR or temperature.
Mm-hmm.
I'll discuss later on how we arrived at what we did. But just doing the biofeedback, we quickly learned, and initially I was disappointed in the quality of the software.
Mm-hmm.
When I thought of virtual reality, I thought of what I'd seen on, I guess, maybe some Disney sites, or in the even in those days, the Sony PlayStation games, or maybe this was later on in around 2002, but the graphics were actually better on the $29 off the rack. Remember that game Doom with the gun?
Yeah, yeah.
That was actually a better experience at $29.99 than this $15,000 program was.
Wow.
But you know what? It looked like a cartoon.
Uh-huh.
And we found that about half the people we worked with wouldn't buy into it. It was too primitive.
Uh-huh.
And for these people, I actually had to videotape with a high definition video camera. This is before YouTube became as popular or as easy to use as it is now. So anytime anybody came in with a phobia, I had to go with a high definition video camera and videotape the scene. We had a huge library here at Behavioral Associates.
Uh-huh.
Because half the people we treated did not want to give up the high resolution just for the ability to get a tracker. Remember, a tracker is a thing where when you, in a basic virtual reality program, you sit down, look out the window to your left, and you're actually looking out a window. When you look to your right, you'll see passengers and an aisle.
Mm-hmm.
You cannot do that with the YouTube videos or any kind of basic video. There's no tracker built into it. So it's a lot cheaper.
So when you were doing this, initially when you would go out and videotape footage to use,
Yep.
what were you displaying it on?
We could actually run the footage through the head-mounted display.
Oh, okay.
Now, certain people, remember, about 1/4 of people who come in for desensitization and virtual reality for fear of flying are really claustrophobic.
Uh-huh.
And they have to be treated a little bit differently. But a lot of these people could not bear having the headset on.
Wow.
Their symptoms were preventing treatment, especially because we found, Harry, that the best way to do it was get the head-mounted display on their heads and then take a scarf and wrap it around their heads, because that gave a much better sense of being immersed in the environment.
Uh-huh.
It blocked out all outside light.
Huh.
And it worked great, but certain people rejected it because they felt too uncomfortable.
Right.
For that, we gave them a couple of options. You could run the program on a monitor, regular computer monitor,
Uh-huh.
but projecting it with a high-resolution film projector worked great.
Uh-huh.
That way, especially if they're leaning back in a recliner or that emperor chair I told you about,
Right.
you could project it onto the ceiling and get a real sense of being immersed.
Right. So since the image is so big,
yes,
and they're close enough to it, it looks more real. That just like when you're watching a small television compared to being in front of a big theater screen, it seems more real.
Exactly. And we found out that common sense told me that the video, the visual aspect was the most important part, because you're using 3 of your senses. You're seeing it,
Mm-hmm.
you're hearing it, either through speakers or through the headphones,
Mhm.
the head-mounted display, but you're also feeling it.
Uh-huh.
Now, we all know that when a plane takes off, a big part of the experience is the sensation of the plane rumbling.
Right.
Well, let me give you some perspective on this device called the butt kicker, which was originally made for the gaming community.
Sounds pretty interesting.
Well, when you go to a Sony IMAX theater and the seat rumbles, it's got a
Uh-huh.
subwoofer built. That's 90 watts. The
Uh-huh.
butt kicker is 1100 watts,
Wow.
and we attach it to the chair, and it's amazingly powerful but amazingly sensitive.
Uh-huh.
So much so that for our driving phobic patients, I've taken the camera in my car. I've got an Audi S4 it's got it's a stick,
Uh-huh.
and you can actually feel the transmission. And I
Wow.
can tell the difference between one transmission and another, whether it's my car or not. That's how sensitive it is.
Wow.
And I tell you, it's incredible how captivated and immersed you become when that plane is rumbling down the runway. You can feel seemingly every bump in the runway, and when the thing takes off, you feel the landing gear coming up.
Wow.
Up in the clouds, we get thunderstorms and lightning. Now to enhance the effect, when the thunder comes on right before it, I'll flash a flash from a digital camera, and that'll look like lightning.
Huh. So you really make it a real experience.
We try. Now, initially, when a person first comes in, we want to see how immersed they're getting. So to collect baseline data, we're basically doing GSR.
Uh-huh.
And we can, GSR, as you know, is a pure measure of visceral arousal, measuring perspiration. But, long before you perspire, long before fluid breaks the skin, beneath the skin, beneath the fingertips, tiny, because electricity moves more easily across fluid than skin tissue,
Mhm.
the change in resistance is picked up right away
Mhm.
in GSR, and you can pick up very subtle nuances of emotion.
Mhm.
I do a lot of it when I do couples therapy.
Right.
I found that and this has nothing to do with biofeedback per se, but I'll videotape my patients when I do couples therapy and have them hooked up to GSR simultaneously. And I'll run another video camera videotaping the movement of GSR while they're talking.
Uh-huh.
So there's a couple of different layers to this stuff, and it's very illuminating, I can tell you.
Yeah.
Because what people think they're communicating and experiencing versus what's really going on, well, let's just say it generates a lot of conversation.
Uh-huh. I bet.
But for these fear of flying people, we'll get baseline data, see what happens at various points of the flight. Certain people are terrified by the takeoff.
Mhm.
Other people are relieved when the takeoff is done, and they feel like the worst part is over. But other people, they fear being up in the air and having nothing to do. And
Uh-huh.
it's that's why the long flights, like to Asia or even to Europe, are really scary.
Uh-huh.
It's remarkable how, because fear of flying is a basically irrational response,
Mhm.
the numbers support that.
Right.
But we also know that our brains are very good associative, but not real good statistically.
Right.
So we can't really comprehend the difference between 001 and 00001, whereas one might be 30 people and the other 300,000 people. Our
Yeah.
brains aren't good at that. But as I said, it is good at associations, which is why the treatment is so effective. Because a lot of times people will say, well, this is a bunch of baloney. It's not the same as flying. This virtual reality, I get scared, but not nearly as scared. And we say, well, hold on, that's not a bad thing. That's actually a good thing, because if it were identical to flying, then you couldn't do it.
Right.
You'd have the same panic attack in virtual reality as you do in the sky.
Right.
And it's kind of like when you get a flu shot.
Mhm.
That's an inoculation. And there's a reason why this is called stress inoculation training.
Right.
Because when you get a flu shot, you get a small dose of the disease, and the body has experience fighting it off. Then, when you really do get exposed, the body's had prior experience and knows what to do.
Mm-hmm.
Same thing with this. That's why we don't need a full-blown panic response. They just have to feel twinges of anxiety in the same direction.
Mm-hmm.
So, say if they're flying and you're rating it, from on a 1 to 10 point scale, it's 9.5, and with virtual reality, it's 4.5 out of 10. That's a good thing.
Right.
All we have to do is get them moved in that direction, and they're going to be good candidates.
Mm-hmm.
Those rare people where they'll not only report not feeling anything at all, but GSR doesn't move, that's flatlining.
Mm-hmm.
We can't help those people, and we refer them for other kinds of treatment.
I see.
But that's very rare. I may be less than one case a year.
Uh-huh.
Most people, you can harness enough of the autonomic nervous system to get them going.
Okay. So now once you assess them in that way using the skin conductance, what do you do after that?
Okay. Then first thing I do is teach them proper diaphragmatic breathing.
Mm-hmm.
Most of the time, these people are hyperventilating without even realizing it, and neck and shoulder tension. It's incredible because people think you're a mind reader when you say to them, not only are you hyperventilating, but do you have cold hands and cold feet? Do you sleep in socks in the winter? Very common for these people.
Mm-hmm.
The sense of depersonalization is a big deal. That feeling of unreality, and the classic anxiety attack stuff.
Mm-hmm.
But I'll train them in heart rate variability. So I'll hook them up to 3 of the Thought Tech devices.
Mm-hmm.
We use the 8-channel device. I forgot what it's called. Procomp.
That's the Procomp Biograph Infinity.
Yes, that's it. We do GSR on the fingertips. We use the respirate device around the diaphragm, the belly.
Okay.
And we do GSR.
Mm-hmm.
GSR is measuring the total experience.
Mm-hmm.
So we're trying to get them, and I'm sorry, heart rate also. I apologize. To get heart rate variability. And what we're looking for is to train them to breathe at about 6 breaths a minute. So it's about 5 seconds in, 5 seconds out. And within a few minutes, most people can not only see that nice sine graph that gets produced, but heart rate will begin to rise and fall with inhalation and exhalation.
Mm-hmm.
And that's the beginning of respiratory sinus arrhythmia. Now, what we're looking for is the biggest swing in heart rate possible. So if somebody's resting pulse is 70 and at peak inhalation goes up to 85 and then drops to 60,
mm-hmm.
they're getting a 25-point swing.
Mm-hmm.
Let's say at 5 3/4 breaths per minute, they're getting a 32-point swing.
Mm-hmm.
And that's the rate we're going to use.
Mm-hmm.
So once I have that person's optimal rate, I play blues harmonica. So I'll grab a harmonica.
I didn't know that about you.
Yeah, right here. Let's see. Right here. And playing a harmonica is breathing. Remember that? So breathing in, once I'll get their exact rate, and I'll record it on my cell phone or on their cell phone if they have a recording device on it. So it's like at their exact rate. Then we ask them to practice that on a daily basis.
Mm-hmm.
Using headphones, they go to a place where they can begin to learn this technique. This is a very important part of the treatment. And you can see how much they've really practiced because you'll see a big difference in the following week.
Mm-hmm.
Now, it doesn't occur right away that you figure out what their optimal respiration rate is. It's usually between 5 and 7 breaths a minute,
mm-hmm.
but it varies from person to person. Now, some people have a tough time with the concept of abdominal breathing.
Right.
They'll do what in golf is called the reverse pivot. You know, it's the worst, or a bat, or a baseball, a hitter in baseball will, as they're driving through the ball, that we're supposed to do, whether you're hitting a golf ball, a tennis ball, or a baseball, if you're right-handed, you shift your weight onto your left foot and move forward. You shift your weight from the back to the front. That's the proper weight shift. With breathing, when you're inhaling, as you're filling your lungs, okay, your belly comes out like filling a basketball. And when you exhale, your belly goes in.
Right.
Certain people just can't get it, and they do the opposite. When they inhale, the belly goes in, and vice versa, which creates all kind of problems.
Right.
You need to teach them how to do this.
Right.
And once you get their optimal rate, you can see the GSR falls off the table. And they get extremely relaxed. So relaxed that they'll usually tell you they feel like they're about to fall asleep, which is always a good sign. It's also a reason why we tell them never to do this when you drive in a car.
Right.
But we use a modified version of this to treat insomnia, and it works great. Whenever people can't sleep for more than a few minutes, I have them do belly breathing, and eventually they're going to pass out.
Right.
That doesn't work for insomnia. I make them do push-ups and sit-ups. And that, with the RSA breathing, they usually wake up on the floor. But anyway, once they've learned the breathing, then I expose them to the virtual reality very slowly. Now, it's important to remember that different people are phobic about different parts of the flying experience. So you have to customize your program based on your patient. But you can always tell what the exact part of the phobic stimulus is that makes them the most anxious, because you're monitoring GSR. That's where the biofeedback, as far as I'm concerned, is something you just need to have to do this.
So that's where the value of combining them comes
Absolutely. Yeah. Both the biofeedback becomes both a monitoring device and a treatment device, because you're using it for counter conditioning. Initially, you're using it to tell just how phobic they are, how anxious they are. And there's another piece to this also. When patients can see what's going on, that their autonomic nervous system is on a computer screen, it legitimizes what you're doing, and which leads to big improvements in compliance. Remember, they're only seeing you 12 to 16 sessions and they're done. Within a year, they've forgotten your name. Now, some people like to come back once a year for like a booster treatment, but it's really not necessary. By far, fear of flying is the most common phobia we treat, with number 2 being public speaking anxiety. But for some odd reason, it's very rare for a person to have both. I have no idea why.
Interesting.
Yeah, I have no idea why that is. Maybe 1 in 10,000 does. There's something about our DNA that I don't understand.
Yeah. So
anyway,
you probably get a lot of business people, and
that's most of my clients that we see here are Wall Street or finance people, for a couple of reasons. There's a lot of pressure for them to fly. It's not just going to Florida for the holidays with the family, which is, of course, important. But if you've got a job where you've got to fly out to the West Coast to see a client and you can't go, they're going to replace you.
Right.
One of the difficult cases we saw here, and this actually led to an arrest. A woman came in for treatment who she's an attorney, and she was passed over for partner because she couldn't fly. And the client on the West Coast that the firm had, and he complained about her. And even though she was a very good litigator, her fear of flying was so bad that she missed this big opportunity. And then, in what became one of the biggest mistakes of her life, she was so angry about being passed over, she decided to fly to California to talk to this client. So by herself, she impulsively booked a flight, got on a plane, and about 90 minutes into the flight, her panic attack really started to grow.
Oh, boy.
There were these two women in the front row. And this will give you an idea about how otherwise very rational people could lose it and
Mhm.
really get off the rails.
Mhm.
Um, this is a woman who was a high functioning attorney, but we all know what anxiety can do to people's rational decisions. There were these two obese women in the front of the plane. She walked up to them screaming, "You girls are really fat. I want you to go get to the other side of the aisle so you balance the plane. Otherwise, we're going to tip
Wow.
over."
Wow.
And they, of course, said no. And then she ran to the door thinking she wanted to jump out of the plane.
Wow.
Now, you can't open the door to a commercial jet. And she didn't even get close,
Right.
even the air pressure. But I think I heard somewhere that only the head flight attendant has a key to open it from the inside. But, at 7 miles up in the air, that door's not opening.
Right.
But she was tackled by some flight attendants and passengers, and she wouldn't stop screaming. They used a camisole on her. They
Wow.
eventually had to gag her. She was arrested in L.A.
Mm.
Federal marshals came aboard, and she took the train back a couple of
Mm.
days. She was one of the few people that had a panic attack in virtual reality.
Mm.
She bolted out of the chair when the plane took off with the completely wired up. She had a headset on and biofeedback equipment and just got out of the doors. I was chasing down Lexington Avenue.
Wow. To get your equipment back.
Yeah. She took 24 sessions,
Wow.
uh, which was the longest we've ever had.
Mm.
So the
Well, you said 24 sessions?
24
I
sessions.
mean, if you think about it, that's really not that bad.
Not really. I mean, it's less than 6 months,
Yeah.
considering how long therapy can last. In psychodynamic or analytic psychotherapy, that's hello, how are you?
Yeah,
Uh,
that would be considered great compared to a lot of other things.
yeah, this stuff works very quickly. It's which you can charge much higher fees for
Mhm.
that reason.
Mhm.
Um, and insurance companies, uh, the ones I've dealt with, and we've kind of um, been able to reason with some of them, not
Mhm.
all of them,
Mhm.
but they understand that we have to charge significantly higher fees because the equipment is so expensive.
Right.
And it's not talk therapy. Uh, we we don't think that we should have to settle for the relatively low fees that they pay, and they've been with us in most cases because they know over time they're saving money.
Mhm.
If somebody's coming in less than 30 times and our success rate is so high, that makes them look good also.
Sure. Do you get some people that um, decide to do this even without insurance coverage because it means
Absolutely.
so much to their career?
Absolutely. I mean, if you've got a job and you're going to fall way back in the pack if you can't fly, uh, people will do anything.
Mhm.
I usually point out to them, think of how much money they've saved by not flying all these years.
Right.
Um, and you know what? It's one of those things where even if, especially if you have kids, and the kids wonder why every year their friends go to Florida and they go to the Poconos. It's because mom won't get on a plane,
Right.
and they're fed up. So um, my experience has been that if you don't deal with this stuff before your kids come of age, you might as well put it in a box, wrap it up, put a bow on it, because you're going to give it to them. Um, this stuff, there's a lot of learning that takes place, and
Mhm.
modeling is a big ticket item for this. It so I'm never surprised when they tell me that that if they have fear of flying, one or both of their parents had it.
Mhm.
In fact, when I do intakes right now, I don't say to the phobic patients, "Do any of your parents have issues with anxiety?" I'll say, "Who are the people in your family that also have issues with anxiety?" That's how
Right.
prevalent. And the genetic factor is a big deal.
Right. Right.
So look, there's a lot of science behind this, but there's also an art to it. And
Right.
the only way to really get a feel for this is through experience.
Mhm. Now
Uh,
you had mentioned the of course the cost of the equipment being one of the big issues as to why people more people don't use this, and then also combining with biofeedback and so on. And you've mentioned YouTube. and you mentioned ways of making it much more affordable. So can you talk a little bit
Absolutely.
about that?
Sure. I mean, I think it's extremely affordable right now relative to what you're going to get back in patient fees because you can charge 2 to 3 times more than what people are charging for verbal psychotherapy because of the expense of the equipment. And also, quite frankly, these are the demands of the market. You're going to be doing something that very few people can get.
Right.
I think right now we may be one of the few groups in Manhattan to offer it. But with YouTube, as long as patients are willing to bypass the use of a tracker,
Mm-hmm.
you can get fully set up for less than $1,000 for
Wow.
the virtual reality end of things. The biggest expense is the head-mounted display, which I think is about $800 for the Sony device.
Mm-hmm.
But well, maybe the butt kicker is maybe $600 with the amp. Uh, but and then of course the biofeedback equipment. Now you don't need the big expense of the Infinity because remember you're only really going to need 3 channels.
Mm-hmm.
So I know that they have one device. It's much less expensive. It has 2 or 3 channels.
Yeah, there's a two-channel device, ProComp 2, where
That's
you
it.
can measure two things at a time.
Legacy or something. Is that it?
Yeah, yeah.
Yeah. And I think there's a 5 channel device also, right?
Right, right.
So that's probably going to be your biggest expense.
Mm-hmm.
And you know what? In my opinion, a psychologist not doing biofeedback is like a physician without a prescription pad.
Wow.
I don't get it. It's such a powerful tool. It's based on academic learning theory. It's one of the few things that psychologists can do that other professionals rarely do.
Right.
Uh,
Well,
and
you know, if you talk about like with the expense and so on, first of all, you have a whole group of people, psychologists and other professionals that are already doing biofeedback. So many of them already have equipment.
yep,
And, you know, I'm just, while you were mentioning the cost, I was just thinking, for instance, you can add the PIR, you know, the HEG
yep,
device to the thought technology equipment, which costs about $1,000 to add that. And that's
yep.
one, you know, adding one modality. Some other modalities would be much less to add. But if you can put together the capability of adding the virtual reality for, you know, somewhere in that neighborhood, that's, you know, that's really pretty affordable.
Yeah, I think so. And at the end of the day, it's exposure therapy,
Hmm.
and you're really allowing your patients to viscerally experience the phobic situation. They're not talking about it, they're experiencing it, which to me is much better.
And so what do you do with the YouTube?
Well, let's say there's a guy I'm working with right now, he is terrified of bridges.
Hmm.
And he's a contractor and he's losing a lot of customers because he can't drive over a bridge.
Hmm.
So if you've got someone, if he's got to get to Staten Island, for example, to see a potential customer, he can't do it. He's afraid to drive over the bridge.
Mm.
So but with YouTube now, you can get any bridge and tunnel in the tri-state area. Whereas we used to have a library because I used to have to videotape it myself, which I'll tell you, interesting. I almost got arrested.
The
I
Homeland
didn't know.
Security.
Yeah, they don't allow you to. They weren't publicizing the fact that you're not allowed to videotape going through the Queens Midtown Tunnel. So here
I'm happy that you didn't end up somewhere in Cuba.
exactly. I thought the cop was kidding when he said pull over. I was videotaping him, almost arresting me. It turned out that after I got him to believe I was who I said I was.
Uh-huh.
Then I had to spend another half an hour listening to him because he had fear of flying. And he had a million questions.
So did he sign up as a patient?
I don't think so, but I was an hour late for a dinner party at my house that night. I got in a lot of trouble. Actually, I got ticketed going 90 up 684 after that. So, but
Wow.
with YouTube now, you can really pretty much get everything
Huh.
there. If you type in uh, riding a bicycle across George Washington Bridge, you'll get a dozen responses.
Uh-huh.
And it's remarkable how good some of that footage is.
So you just use that footage for the content that you use during the sessions then.
Exactly. That becomes a stimulus. For
Wow.
people that are afraid of crossing that bridge,
Mhm.
it's extremely effective.
Wow.
Now, what I usually do for people is right fear of flying patients, for example.
Mhm.
I'll encourage them to take the tram over the East River to
Mhm.
Roosevelt Island.
Mhm.
That replicates a lot of the motion
Uh-huh.
sensation people get. Or I will, for my fear of heights patients or fear of crossing water, I'll ride a bicycle with my patients over, the footbridge that goes Randall's Island. You
Mhm.
cross the FDR.
Mhm.
That's a terrific piece of footage. And by the way, you can also get that on YouTube.
Uh-huh.
I videotaped it myself because I want to see my patients in the video. That
Uh-huh.
seems to have more meaning to them. And this is where you get creative, by the way,
Uh-huh.
because you understand through your patient's self-report all the nuances of their phobia. And there's nothing like it when they have a video of themselves being successful.
Mhm.
That becomes something they can keep on their desktop. And if it's not a long file and you bring down the resolution, you can email it back and forth. And
Wow.
I'll have them watching themselves doing that while they're doing RSA breathing. That deepens the counter conditioning procedure.
Mhm.
There's a lot of things they can do at home that speed up your treatment.
Wow. Well, I see. It seems like you really are being, really artful with combining things. Of course, your clinical background and training, and the technology, really, and not just taking one piece of technology and using it in a very narrow way, but you're combining things and being very creative with it. And your Institute Behavioral Associates seems like it's really it has a reputation for doing this type of thing, using technology in ways that others aren't. So, um, how did is that just because you're in a way a techie, or how does that happen?
Well, I'm definitely a gadget freak. Uh, and I think I attract them here also. um, because we have predoctoral training and postdoctoral training here, so we get a lot of students from the tri-state area.
Uh-huh.
But there's a remarkable thing going on in psychology where men are not going into the profession nearly as much as they used to. When I started grad school, it was 50-50.
Uh-huh.
I have trouble hiring male psychologists. It's the average doctoral program in psychology is 90% female.
Now that you
And
mentioned that, I've been seeing even in the seminars that we do, I've been seeing probably a lot more females, and I was just at the New York Psychological Association conference, and yeah.
yeah, so I, I know it's a sensitive area, but it seems like women are not as interested in this tech stuff as men. Although there are plenty of women here who have taken an interest.
Mhm.
It's just not as common,
Mhm.
unfortunately. And that's another thing. But you know what? The fact that so few people are doing this kind of work should be encouraging
Yeah.
because it allows you to do things that most other people can't do. And you know what? It's extremely gratifying because people get better. And
Mhm.
you know what? When somebody can't fly or can't give a speech or can't drive across a road, and it's really affecting their day-to-day life and their profession, and you get them to do it, and you can pretty much tell when they're going to be able to do it. They think you're a wizard. It's very gratifying,
Yeah.
uh,
Yeah.
and that's why we do this. Um,
Right. So tell me a little bit more about behavioral associates.
well, we opened up in 1988.
Mhm.
We've got I think about 20 therapists on the staff right now,
Wow.
psychiatrists, psychologists, social workers, and We're getting a number of these. They have these programs now where they license. I think it may be a year or two of training. I think it's what used to be a master's degree in psychology.
Mm-hmm.
I believe now you get a license in New York State. But so we see about 400 patients a week. We are a very big training facility.
Mm-hmm.
At any given time, I'd say half of the people here are at some level in training, whether they're doing it postdoc or pre-doc.
Mm-hmm.
They're trying to get their hours for licensure. And then there are senior people here that have been here for a long time.
Mm-hmm.
So I'd say the most junior people here are in their third or fourth year of doctoral programs,
Mm-hmm.
and on up. But I guess I'm proud of the fact that we're really teaching people things, how to do things that really work. And
Right.
I get calls from like people who were here 5 years ago to let me know how they're doing, and usually to thank me. I guess the ones that aren't happy aren't even calling me. Not a random sample, but it's you do get results with this stuff, and
Uh-huh.
at the end of the day, that's pretty important.
Great.
Uh,
And where are you located?
we're at 90th Street off of Park Avenue. Um, so it's 114 East 90th Street. We're online at behavioralassociates.com. You can read about us.
Okay. Great. Well, I appreciate you taking the time to tell us more about the virtual reality and biofeedback and how you use it. And maybe we can take a look at some of the stuff in another time, so we can kind of see some of the stuff that you use. That'd be kind of cool.
Yeah, I mean, do you want to do it now, Harry? You take a quick sweep, or
You're seeing a monitor now, right?
Yeah.
Okay. Now, see right here? This is the virtual reality program.
Yes.
All right, I'm going to crank it up. We're going to go to takeoff. Now, let me bring it around here. Okay, you see these screens right here?
Yes.
All right, so this is what the patient sees in here. Now, watch this, Harry. See this right here, the tracker, the headset. I'm going to turn it. You see how it turns with it? That's the tracker.
Okay.
Does that make sense?
Yes.
Okay, so now let me show you this. The butt kicker I told you about. Watch this. Down here.
Uh-huh.
The subwoofer. I'm going to pick it up so you can see it. See it? Okay, that's the butt kicker right there.
Yes.
All right, now watch this. By the way, remember the scarf? That's what that's for right there.
Uh-huh.
Let me get this thing cranked up.
So is that 3 different screens that are linked together?
Yes.
Okay.
So right now, the patient, with this on right here, we're looking out the window.
Mm-hmm.
So once the thing gets set up, it's going to take the plane off. Now, this right here, you recognize this stuff right here? This is shown on the screen right here.
Okay.
The RSA. Okay, we're going to go to take off. And to reset the tracker, I'll do that. There's the bulkhead right there.
Uh-huh.
And this is the entire, there's the outside the window. this is the rest of the plane. You can actually walk up and down the aisle.
Wow.
In virtual reality, it goes all the way back. Now the plane's just waiting to get clearance to take off.
So you can really get a sense of the size of the display there compared to the laptop.
Right. Yeah, big difference. Yeah. So now you'll feel the vibration. I'm going to put this up here. Can you feel any vibration? That's from the butt kicker.
Uh-huh.
So I don't know if you can. I don't know if you can feel that with the phone.
No, I can hear, but yeah.
Yeah, the whole thing is vibrating. This is the amp right there.
Uh-huh.
That thing is really going right there. See. Now we're up. Now you'll feel landing gear in a second. We'll shut it down. So, yeah. So, show you one more thing.
Uh-huh.
Those bells you hear on the thing,
Uh-huh.
that's all right there. And this is the lightning.
Uh-huh.
That's thunder, actually. So that's the basic idea of it.
So it's translating any of those sounds into vibrations, and that gives the that goes into the butt kicker in the chair.
And it's exactly so that all. And all the while with this, familiar with this screen. This is the GSR screen. This is the RSA screen we use right now.
Uh-huh.
So, I mean, as you know, the nice thing about the thought tech stuff is that you can be creative and build your own screens.
Right.
So that's one of them. Yeah. So that's the basic idea.
That's really cool.
This is the chair I told you about. This goes. So the mount down. This goes all the way to that. So a lot of flexibility. All right.
Great. Well, I appreciate you showing us that. That's really great. So now we have an idea of what the setup looks like. Very nice.
You think that your students taking biofeedback are going to learn this?
I think a lot of them would be interested. I think you have people that have been doing biofeedback for a while and they're using it in the traditional ways, but I think this would give a lot of people another option of things that they can do.
It's a great way to expand your practice, and you can get fees. I mean, we're getting $600 a session here in New York for this.
Mm-hmm.
And because we'll break it down for people, and they'll see it's only a limited amount of sessions, actually less expensive than a full course of typical therapy.
Right, and if it works, it's better for them if they go less sessions and running back and forth, and taking 10 times as long to get results.
The only time it doesn't work, Harry, is when people are non-compliant with the protocol. If they don't practice stuff at home.
Mm-hmm.
Otherwise, it almost has to work. It's pure counter conditioning.
Right.
There's no. It's not. You don't get the nuances of talk therapy. It's just a straight procedure.
Mm-hmm.
The same way that. Remember the movie Clockwork Orange? Remember he was a young Malcolm McDowell was shown those scenes of he was a murderer. He was a violent guy, and they tried to counter condition him by showing him films of violence in Nazi Germany, and they gave him drugs that made him sick. And he became conditioned so that whenever he thought about violence, he would get sick. That was virtual reality, and that was all classical conditioning. We're doing the same thing, except we're using positive reinforcement instead of negative reinforcement. Which is what that was.
Right.
It's, you know, it's straight conditioning. It's all Pavlovian and Skinnerian stuff.
Mm-hmm.